Okay, the first step would be to examine the hands and forearms, checking for any physical abnormalities, colors, and temperature by touching the patient's forearms and their hands. Okay. And then the next step is to check for the radial, ulnar, and brachial pulses, which are here. Here's the radial pulse, and here's the ulnar pulse, and here's where you would find the brachial pulse. And afterwards, it's important to test the capillary refills of the hand. You can do this gently by pressing the skin in their respective areas that you want to check. Just gently. And as you can see, the color returns back within 2 seconds if it's normal. And another area you can also check is also the neobeds. We also want to check range of motion on the patient. Depending on their diagnosis, they could either do passive range of motion or active range of motion. Active range of motion would assess the integrity of the muscles and tendons, while the passive range of motion would assess the joint, which includes the joint capsules and the tissues. When performing passive range of motion, it's important to investigate the end feel. The end feel is the quality of the movement perceived by the practitioner at the very end of the available range of motion. And first we'll go ahead and check the flexion of the elbows. And then we'll check supination and pronation with the arms adducted and the elbows at 90 degrees flexion. And then we can also check wrist flexion and extension. Patients with arthritis would expect to have limited range of motion in these joints, and you might want to ask them if their wrist feels tight while they're moving it. And also they may exhibit swollen wrists. You may also notice a squeaking sound when you move your wrists, and this is called crepitus. And then you also want to check the flexion and extension of the digits. And when checking flexion, make sure that the patient can flex their fingers to the distal palmar crease. And the thumb should also be able to flex to the metacarpal head of the 5th digit, which is located here. And finally, if you want to check for lymph nodes in the forearm, we can check in the epitrochlear lymph nodes, which are located here. And you can do this by kind of feeling around, trying to find that lymph node if they do have any. If the patient is expected to have tendinitis, we will want to check by isolating the elbow, the wrist, or the hands. When testing the lateral epicondylitis, you need to identify the lateral epicondyle, which is located here. And here is where the extensor muscles originate. And in order to test this, you need to palpate the lateral epicondyle and create resistance while the wrist is extended. And pain will be elicited on the extensor origin if the patient has lateral epicondylitis. Same thing applies for a patient with medial epicondylitis, or often called golfer's elbow. Palpate the medial epicondyle and create the resistance with the wrist flexed and forearm pronated. Pain will be elicited on the flexor origin if the patient has medial epicondylitis. Okay, to check for tendinitis in the wrist, you need to identify 6 dorsal compartments, and each compartment has a tendon in them, and they can all become inflamed. Here are the 6 dorsal compartment. Here's 1 and 3, which forms the snuff box. And then we have the second one, the third, the 4th, and 5th compartment. De Quervain's is tendinitis involving the extensor pollicis brevis and abductor pollicis longus, which is the first compartment, and this can be used by doing the Finkelstein maneuver test, which involves holding down the thumb and ulnarly deviating the wrist. And if this elicits pain, then the test is positive. So you would do this and see if it elicits pain on the first compartment. When the patient is suspected of flexor carpi radialis or flexor carpi ulnaris tendinitis in these regions, you can test it by flexing the wrist and creating resistance while palpating the flexor carpi radialis or the ulnaris. Pain while palpating this in these two areas would test positive for tendinitis. When you're testing the flexor carpi radialis, you want to have them radial deviate this way before providing resistance, and then for the ulnaris, you want them ulnarly deviating before providing the resistance. Patients can also have pisotriquetral arthritis, which can be treated by which can be tested by creating resistance while patients is ulnarly deviated and flexing the wrists. And here's the pisiform. And you want to make sure that you're grinding down on the pisiform while having the patient resist to elicit the pain. And then you can also check for tendinitis in the extensor pulsus longus that can be tested by creating resisting while the patient extends the thumb. And you are going to palpate the third compartment. And to test the extensor digitorum, you palpate the fourth compartment while you have the patient extend the fingers while the palm is facing down. The extensor carpi ulnaris runs here on the ulnar aspect of the ulnar head, and it can elicit pain by slipping over the ulnar head and creating tendinitis. Symptoms include wrist pain and loss of grip strength. Golfers are at risk of developing this type of inflammation, and this is tested by extending the ulnarly deviated wrist while palpating along the extensor carpi ulnaris. Treatment depends on the extent of the injury. Conservative treatment consists of rest, immobilizing the wrist with a splint, which is shown in the picture here. Okay, now let's start with the bones. Here is the Lister's tubercle, and here's the head of the radius, and here is the head of the ulna, and the scaphoid, the lunate, and the triquetrum. If there is pain present when blotting the triquetrum with the lunate together, this might indicate a ligamentous injury in that area. Now, in order for you to find the lunate, you can find it by locating the Lister's tubercle on the radius and also going distally 1 centimeter and also 1 centimeter towards the ulna away from the Lister's tubercle, and you can find the lunate here. You can also test for ligamentous injury between the lunate and the scaphoid here, and you can also do this by blotting it like this and seeing if this elicits pain. If you suspect a scaphoid fracture, you can test this by finding the snuff box, which is located between the first and third dorsal compartment, and you can palpate that area and see if they feel pain in that area also.
The scaphoid is located just above the head of the radius and the base of the thumb, like it is shown in this picture. A scaphoid fracture is usually caused by a fall on an outstretched hand with the weight landing on the palm.
Alright, let's now identify the carpal tunnel. The carpal tunnel can be found by identifying the area just to the ulnar side of the flexor carpi radialis, which is here, and then also the distal flexion crease of the wrist, which is here, and then the Kaplan's cardinal line, which runs from the thumb web space to the hook of the hamate, and then also the ring finger axis, which is here. So the carpal tunnel is located here, and it contains the median nerve, the flexor digitorum profundus, the flexor digitorum superficialis, and the flexor pollicis longus. The Tinel's test can be done by tapping the median nerve, which will elicit a tingling response or pain on the tip of the fingers, if it is positive. And then also you can do a carpal compression test by applying pressure on the median nerve while flexing the wrists, and this is considered positive again if the patient feels a tingling sensation at the tip of their fingers. And then we also have the Guyon's canal, which is located on the ulnar side of the carpal tunnel, and the ulnar artery and the ulnar nerve runs through here. And again, we can also do a Tinel's and carpal compression test to test the ulnar nerve, and a positive response can be concluded if there is pain or tingling sensation on the pinky or on the ulnar side of the fourth digit.
Here's a picture of what the median, radial, and ulnar nerve supplies in the hand. A positive test in both Tinel's and carpal compression tests would correspond to the areas in where each nerve supplies, like shown in this diagram.
A Watson scaphoid shift test can be done to test the wrist instability, which can be caused by periscaphoid arthritis or scaphoid lunate instability. First, you need to place your thumb on the scaphoid tubercle, which is located here, and then slowly releasing as you start from ulnar deviation and radial deviate like this. And what you want to do is while you're pressing onto the scaphoid, you want to check if there is a pop or jolt while you're doing this. And if there is, then it tests positive for wrist instability. Okay, you can assess the sensation in the fingers by using the 2-point discrimination test. This test is usually done by using a specific tool called the discriminator, but however, this time I will use a paper clip in this video, which is adjusted to be 5 millimeters apart. This test can be done by randomly switching off from 1 point or 2 points like this, and have the patient recite whether or not they feel the 1 or 2 points each time you touch them with it. And if the patient can discriminate between 5 millimeters or less, then their sensation is considered intact. A dynamic test can be done by moving the paper clip along the finger to see if they can discriminate between the 2 points as well. Alright, the ulnar nerve runs here and down the down posterior to the medial epicondyle. And it runs here through the cubital tunnel and splits between the flexor carpi ulnaris and then travels down to the hand. The ulnar can be pinched from anywhere from 10 centimeters proximal to the medial epicondyle and 6 centimeters distal. And if there's compression at the elbows, the patient may feel numbness on the dorsal aspect of the forearm. And hand on the ulnar side. If there's compression on the wrists, then the patients may feel normal on the dorsal aspect of the hand, but feel numbness on the palmar aspect, which will be here. And severe ulnar nerve symptoms may affect the intrinsic muscles of the hands, and patients might not be able to cross their fingers. And the first dorsal interosseous muscle can be tested by using the Frohman's test. And for the Frohman's test, you're going to have the patient try to hold the card in between the thumb and index, and you're going to pull on it. If the patient ends up bending the thumb to keep a hold of the card, then this indicates a positive Frohman's test. Okay, there are 2 flexor tendons. There's flexor digitorum superficialis and there's also flexor digitorum profundus. Now, flexor digitorum superficialis inserts into the base of the middle phalanx and can be tested by having the patient flex the PIP joint while all the other fingers are extended. And this isolates the flexor digitorum superficialis by not allowing the profundus to flex in the And then we also have the flexor digitorum profundus, which inserts into the distal base of the distal phalanx, and its action is to flex the DIP joint. It can be tested by individually having the patients flex the DIP joint of the fingers and applying resistance to the distal phalanx. So you can do this by having them flex, and then applying resistance, flex, applying resistance, and you can do these individually. And by applying resistance, you can measure how strong the muscles are. Okay, if patients have a radial nerve palsy, you will see a wrist drop. So there'll be a drop of the wrist, and this is because the radial nerve supplies all the extensors. And so without the radial nerve, the wrist wouldn't be able to extend by themselves, so you would see a wrist drop. And also in a radial nerve palsy, the patient will probably not be able to bring up the thumb like this around to the dorsal side of the hand. Sometimes the patients will actually be able to extend their fingers in this position, and by activating the intrinsic muscles of the hand. So be aware of that when you're looking for signs of radial nerve palsy. Even though the radial nerve supplies the extensors and the fingers can extend, the fingers usually can extend because of the intrinsic muscles. And then also you can test the extensor digitorum communis, which you'll have the patient make a fist and then extend the MCP joint like a claw. And you can also test the strength of the muscles by providing resistance on the proximal phalanx like this.
Patients with ulnar nerve palsy will have a clawing of the hand of the little finger and the ring finger. This is commonly called the ulnar claw. There will be an hyperextension of the MCP joint and flexion of the IP joints. In a Boutonniere's deformity, there will be a neutral or flexion at the MCP joint, flexion at the PIP joint, and extension at the DIP joint, just like how it's shown in this picture. It commonly happens due to a laceration in the central slip of the extensor mechanism. Here's a swan neck deformity. There will be a hyperextension at the PIP joint and flexion at the DIP joint. It commonly happens due to a laceration in the lateral band of the extensor mechanism.